我都要开始喽。我终于可以开始了。
Okay. Good morning and good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po holds retirement virtual meeting. We are honored to introduce Dr. Ming Lim as our invited speaker. Dr. Lim graduated from National University of Singapore and underwent residency in otolaryngology. He pursued head and neck surgery at his subspecialty and was awarded the Ministry of Health Overseas Training Award to undergo head and neck oncologic fellowship at the University of Pittsburgh Medical Center in the United States of America. He is presented a senior consultant head and neck surgeon at Singapore General Hospital, Department of Otolaryngology, head and neck surgery, and as a associate professor at Duke NUS Medical School. He serves as the director of the Department of Clinical Translational Research, SGH. He is a surgeon scientist and PI of the Translational Head and Neck Cancer Immunology Lab at Academia. He served as a council member of Asia Pacific Thyroid Society, board member of Singapore Society of Robotic Surgery, and member of Asian Society of Head and Neck Oncology and Translational Head and Neck Research Committee at the American Head and Neck Society. His research interest includes cancer immunology and immunotherapy for head and neck cancers, robotic, minimal invasive surgery, and real-time tissue analysis. Today, Dr. Lim presenting topic is surgical paradigm in treating recurrent NPC. Please give a round of applause to welcome Dr. Lim.
Hi, morning everyone. Thank you, Chwee, for the kind introduction. Indeed, it's a pleasure to be here celebrating Peter's vast achievement in hair and neck, and I'm really happy to share this topic, which is on the changing paradigm in the management of recurrent NPC. Can everyone see my slides well and hear me well? Okay.
Yes.
All right. Thank you so much. So, all right. So without further ado, I just want to begin the first introduction with the friendship that we have with Peter and the community in Asia. These are the meetings that we have been involved together in various parts of the world, and as well in overseas. And another good friend, Chris, who is also from Singapore, Ravi from Malaysia, and this is Barry, I think was in one of the academy meetings. And Peter also made several trips to Singapore, as well as for me and my family to Taiwan. So I think really thank him and family for their hospitality. These are just to show forth additional slides. So just to show that our friendship has gone for many years. And this is the tie from him, from Asiano. I think it was in 2014 where I met him first in New York and we connected. Right, so just want to acknowledge Prof. Jean Myers. I think Peter and I have the privilege to train in Pittsburgh, as well as I think many other surgeons from Asia. So really want to acknowledge Jean for his vision to connect with the world, international fellows, and now hopefully we can have a legacy for Pittsburgh. All right, so the other thing about Pittsburgh is that we have this mantra about healing with steel, primarily because it's a Steelers city. So the thing is that it is a very surgically orientated treatment for hair and neck diseases. And I think we are all privileged to have our training at Pittsburgh, the beautiful city. All right, without further ado, I'll just go into the main topic for today. I do not have any specific disclosure for this presentation. I'd like to outline the background of recurrent nasopharyngeal cancers, and as surgeons, what are the surgical approaches that has evolved over the past decade, giving some clear examples of what how these patients may look like. And in the next final portion, just to discuss some of the future directions of how as surgeons can we improve the treatment of patients with recurrent nasopharyngeal cancers. So I understand this is a ENT community, but certainly everyone is very familiar with this cancer in Asia. It is highly endemic in this part of the world. Primarily, it is a disease that is associated with a virus called the Epstein-Barr virus. And as a treatment, the main treatment for NPC is not surgery. It is actually radiation with or without chemoradiotherapy for the non-metastatic cohort of patients. If you look under the microscope, this is how the NPC will look like, and it's very distinct in this part of the world compared to other variants like the squamous cell cancer of the nasopharynx in the Western population. If you stain the cells with EBV, which is a surrogate for the virus, EBV, this is how it looks like. Quite ubiquitously, it is all EBV positive on EBV staining. So the current paradigm for NPC is as illustrated in this table. I'd like to focus today's talk mainly on the recurrent, non-metastatic, where surgeons are called into to do surgery for this group of patients. And when it's not surgically resectable, then the options of re-radiation comes into the field. So we published our Multi-Ethics Society NPC cohort years back, and we looked at the data, which is quite comparable with an overall survival about 64% and disease-specific survival about 85%, quite established figures in Asia. And we look at what are the predictors for poor outcome, meaning for future relapses. Certainly patients with more advanced nodal disease and with metastatic disease at outset certainly has a very poor outcome compared to others. So for recurrent NPC, that occurs between 10 to 15%, up to 20% in some studies, where the patients, after receiving definitive chemoradiotherapy, suffer a distant local relapses in the nasopharynx. So for surgeons, typically, if it's a recurrent T1 or 2 disease, this is clearly a salvageable disease with surgery. But when patients has T3 and T4, then generally this is not surgical salvageable. But in select cases of T3, i.e. like in the anterior face of the sphenoid involvement, surgery can still be undertaken with comparable outcome as the early diseases. So this is a landmark study published by our Chinese colleague in Sudyat Singh. Certainly, they have demonstrated that patients with recurrent disease that is considered resectable, comparing endoscopic nasopharyngectomy with re-IMRT, it found that patients who had endoscopic surgery have a much superior survival outcomes compared to those patients who had re-irradiation. And this is just to show the survival curve. The blue curves are those patients who had surgery, whereas the red curves are those patients who had repeat IMRT. So certainly it's very clear that whenever feasible, surgery should be the preferred option for recurrent NPCs. And this is important to look at the toxicities of treatment. When they compare the two arms treated with surgery or radiotherapy, they found that the patient who had surgery, certainly you can see the complications are still present, but generally in the single-digit figures, whereas patients who have re-RT overall, the toxicity for grade 4 and 5 is about 20% of severe toxicities among patients receiving another dose of radiotherapy. So this is a nice review with our colleagues in Singapore, the age of disease, the performance status, recurrent T4, T3 diseases, overall tumor volume of more than 38, and certainly the time to recurrence or relapse is also a key important prognostic factor. And finally, the absolute EBV titers in the blood is also a poor prognosis factors among this group of patients. At the same time, for the surgeons, we did a multi-center review of this topic, and then Peter is also part of this review committee. And this was published about 3 years ago in Oral Oncology. Similarly, we summarized the current landscape of recurrent NPC in terms of the surgical approaches, talking about midline approach through endoscopic and more locally advanced disease where an open approach will be required. And we talk about some of the nuances in terms of close involvement to the internal carotid artery. What are the possible scenarios surgeons can undertake in this highly complex nasopharyngectomy surgery? So I just want to start with the endoscopic or the midline natural orifice approach. Certainly, the transnasal is the preferred option, I think, in many centers because of the advances in endoscopic skills as well as technology. Certainly, with or without a transpterygoid approach, you can certainly expand the field of your resection margins and remove a large majority of recurrent T1 and up to T2 recurrent NPC cancers. Right, so in terms of selection, this will be an ideal candidate because the patient has a very localized recurrence right in the close to the roof of the nasopharynx. And on MRI imaging, there's still a fair distance from the tumor from the internal carotid artery as illustrated on the MRI scans. And when you do a nasopharyngectomy, whenever possible, we will raise a contralateral flap, nasal septal flap. And this is how it looks like after resurfacing the nasopharynx with a local pedicle flap, which certainly aids in the recovery of the patients after endoscopic salvage nasopharyngectomies. In terms of open approaches, there are many approaches that have been described. I think Hugo Fish was the first to describe the lateral approach to the nasopharynx, and certainly other surgeons have described the mid-phase degloving approaches or partial maxillectomy approaches. But certainly for open approaches, I believe the workhorse for nasopharyngectomy is still the maxillary swing, because this gives a very excellent exposure of the entire nasopharynx and with good exposure to the lateral wall of the nasopharynx. The side effect for this approach is the relatively high prevalence or incidence of a palatal fistula among those patients who have prior irradiation of up to 10 to 15%. So this was first described by our colleague from Hong Kong, Professor William Wei. I believe this publication was in the 1993, where he first published this approach of a maxillary swing approach for nasopharyngectomies. So for recurrent NPC, there are larger, such as in these instances, where it's creeping to be involved, the floor of the sphenoid, but still resectable because the sphenoid sinus still looks well aerated. Open approach maxillectomy swing is preferred rather than an endoscopic. This is to show how the incision is made. You make a standard rhinotomy, lateral rhinotomy approach with a Dieffenbach inferior ciliary infraorbital extension to expose the entire maxilla as indicated. And this is just to show after the swing is done, this is the entire exposure that you can have with the nasopharynx. This is the buccal fat that will be inevitably exposed when you do the swing approach. This is to show the midline hard palate maxillectomy scars. Some people prefer a midline, but some have veered towards a paramedian just to avoid the high prevalence of a fistula in these instances. So this is a video just to demonstrate the full exposure after the swing is done. The whole maxillar face is then rotated laterally, and this is to show the entire nasopharynx demonstrated after the swing approach as indicated. So this is to show the defect after a nasopharyngectomy using an endoscopic for visualization. This is to show the clivus. You can actually drill the clivus just to get an additional bone margin. This is the left nasopharynx margin. This is a soft palate incision. The C1 and the clivus will be fully exposed in the midline. And you can really expose the internal carotid artery and trace it as far superior as necessary in order to remove disease in a paranasopharynx region. In these instances, certainly a free flap reconstruction is required to resurface and protect the carotid artery after resection. Just to highlight that even small cancers, you may sometimes require a open approach, as in this patients. Although it looks very small, but on imaging, it certainly extends far deeper than is appreciated. And in this instance, where it is close to the carotid, usually up to 1 millimeter, we would prefer an open approach so that we can have good access and control of the carotid artery in salvage nasopharyngectomies. This is to show the same patient after an open nasopharyngectomy. I just want to highlight the pharyngobasilar fascia, which is highlighted in yellow. This is a very important landmark for surgeons because this, first of all, it is a nice barrier preventing the cancer from invading through the pharyngobasilar fascia into the prevertebral space. And that certainly is our deep margin for most of our nasopharyngectomy procedure. And if you were to find the pharyngobasilar fascia in the midline as you do the surgery, you can actually peel off the entire nasopharynx in a very nice plane laterally until you you come into the internal carotid artery. So that is really a landmark. How do we find the ICA intraoperatively is I also like to use the intraoperative Doppler. So that allows us to actually try to Doppler and see where the proximity of the ICA intraoperatively during salvage surgery. So unfortunately, about 2/3 of patients are not resectable when the time of diagnosis because they have sometimes progressed to intracranial involvement, as you can see in these instances. And this is to show the carotid siphon at the posterior edge where the tumor is really abutting onto the ICA. In these instances, in my opinion, it is no longer a surgical disease for salvage, although other centers have performed more extensive surgery by doing internal carotid bypass to do this also en bloc resection. Just to be mindful, although the tumor may look small, but if you need to look at an MRI carefully, there will be like perineural involvement. If significant perineural involvement of V2 or the median that tracks intracranially, these cases are also not good ideal candidates for salvage surgery. And when there is a significant clival erosion, as you can see, about 2/3 of the clival bone is already eroded by the cancer. Certainly, this would not be a suitable candidate for salvage surgery for recurrent NPCs. NPC is peculiar because besides recurring at the nasopharynx, there are also some atypical sites where it can recur. This is an unfortunate patient where he had recurrence over at the frontal sinus. As you can see, there was a PET lighting up in the frontal sinus, and corresponding on the CT scan, you can see this soft tissue bulge that is evident. So we brought the patient to the operating room thinking that it could be another pathology. But unfortunately, when we open through an open approach to approach the lesion, and this is to show the endoscopic visualize of the frontal sinus tract, it all came back to be recurrent NPC. So NPC is quite unique in the sense it can recur in very atypical sites. So as surgeons, just to be mindful that you have to exclude the possibility of a recurrent disease, especially in the sinonasal area in the patient who had history of nasopharyngeal cancers. Skull-based recurrence certainly are not candidates. You can see this patient has a PET light up here. As we open the sphenoid sinus, as on the right side, you can see this irregular tissues on the sphenoid sinus, and this was biopsy proven to be recurrent NPCs. At the same time, just to be cautioned that the ORN around the skull base is also fairly common, so you need to be cognizant that in this particular patient who has seems like a very erosive disease over the skull base, and we brought the patient back for debridement, debridement, and biopsy, and this turned out to be a osteoradionecrosis of the skull base in this particular patient. So some nuances that we need also to be familiar with. For neck disease, usually modified radical neck dissection. If the disease are fairly small and low volume, certainly you can preserve some of the critical, the non-lymph bearing structures, such as the internal the external internal jugular vein here. But in more instances, I think the idea is that to do a more comprehensive neck dissection, because the high preponderance of extranodal extension in recurrent neck diseases in NPCs. Sometimes they may recur isolated in the retropharyngeal lymph node. This is challenging because it's hard to really biopsy the retropharyngeal lymph node. Some groups have looked at ultrasound guided transnasally to biopsy this lymph node, but certainly this area can be a difficult and challenging location for us to manage. As you can see, the retropharyngeal lymph node typically would abut the ICA. So doing it removal from a transnasal, transoral approach can be challenging because of the internal carotid artery, which is typically in the posterior lateral relationship to the lymph node in this region. This is not an NPC patient, but is a patient with oral head and neck cancers where we have to do a retropharyngeal lymph node dissection. Because it was an open approach, I can see the anatomy of this location is highly deep, because you can see this is a posterior belly of the digastric. Once you find the hypoglossal nerve, you find the styloid process, you then trace it more medially along this plane, and that will get you to the skull base, to the retropharyngeal node area. So you can imagine coming to do the retropharyngeal neck dissection transcervically is highly difficult and challenging because of as you go superiorly, it is tunneling into a apex, which can be challenging because the ICA will just be in the vicinity. Next, I would like to highlight some new developments in the space of ENT. Certainly, the single port robot is coming into the field. Unfortunately, in Asia, a lot of not many countries have the single port system highlighted here. We do have previously the Met Robotics with the Flex robot, but unfortunately, it is now no longer in the market. I had the privilege to test on this robot in Boston. This is a cadaveric dissection done in Boston by the company. And this is just to show how the docking is done transorally, transpalatal, without splitting the palate, by having two Neladens catheters to do palatal retraction. And this is to show a video that was done on the cadaveric dissection, and just to illustrate some of the technology with the single port system that can be used to drive it transpalatally. And you can see now your imaging is completely turned around. So this inferior is the vomer bone. So this is a superior of the nasopharynx. And you can see that using these micro instruments, you were able to do a complete mucosectomy of the nasopharynx, as it were. You can see that this is using the Flex robotic system, and you can peel off the entire surface of the nasopharynx through transpalatal approaches. Making cuts on the eustachian cushion is a bit is possible, but you get a lot of charring because of using it with the Bovie cautery system. And this is to show it how you peel it off the cliver bone and then reflect everything superiorly, and then finally delivering out the specimen from the nose or from the palate in this case. So this is just the remaining video showing how you can resect the portion of the prevertebral area, and this is show the defect of the entire nasopharynx after a transpalatal resection. All right, certainly in terms of development of robotic technology, there are advances made in this space. There are engineering where they have micro channel, allowing us to put in more instruments through a single port access. And there are also haptic developments with a flexible robot so that the surgeons can actually perceive the haptic feel of the robotic system. This is a review that I showed earlier. So the key takeaway from the review is that margin certainly is a very important prognostic marker for salvage nasopharyngectomy. The risk of relapse is nearly 40% for a positive margin versus about 5 to 6% for a negative margin. And overall success is approximately about 2/3 or 70%. But one of the problems that patients face after salvage nasopharyngectomy is about up to 40% of this group of patients suffer from distant cancer relapses, meaning the patient had good local regional control, but when the patient relapses, it recurs in other organ sites, such as the lung or the bones. So this is a publication that we show that the relapse status is also a good prognostic marker. What we define as relapse status is the time to relapse, whether it's 6 months from the time of completion of chemoradiotherapy or after 6 months. And we found that there is a clear separation survival curve. So if patients have residual disease in the nasopharynx after chemoradiotherapy, if you do a salvage nasopharyngectomy, they do much better than patients who have relapsed beyond 6 months after definitive treatment. In terms of the future direction, certainly we want to diagnose this recurrent disease as early as possible because we can then use less aggressive or morbid approaches, such as endoscopic approaches for salvage surgery. I would also like to talk about some of the technologies that we can use using cancer surveillance, using liquid biopsies, or a spectroscopy technique that complement the existing white light endoscopy. And also like to talk about some of the clinical trials where we can use either adjuvant or neoadjuvant immunotherapy with chemotherapy before salvage surgery, and how does that look to improve the risk of improve the survival of this group of patients. This is a review that we did for reviewing the current landscape for liquid biopsy for nasopharyngeal cancers. You can look at this in Cancer Communication. It's an open access, so it's highly you can easily download from the internet, but certainly it is a very complicated, not complicated. There are many types of strategies which is beyond the talk today. But I would say the commonest techniques that we use in our clinical practice is the liquid biopsy using cell-free DNA for EBV virus. So next, I'll move on with optics development. So this is nasopharyngeal cancers. This is how it looks like on white light endoscopy, and we will then biopsy to confirm the disease and look at the biopsy by the histopathology. And we were thinking aloud whether there's a possibility to develop a rapid objective screening for NPC. So we were connected to a researcher in NUS where they look at this technique called a Raman spectroscopy. So this basically can use real-time molecular fingerprinting. And what it does is that it can be connected to the endoscope system. And this is the 5mm probe that can be inserted through the nose, where we will then, the Raman probe will then contact the tissue, and they will fire a near infrared laser signal. And based on the reflection of the signal after the laser, the machine will then analyze the signals. And based on the different tissue composition of that signal, you will then see the molecular fingerprint of the tissue that you are surveying. So it can help us identify whether this is a high-risk signal or whether this is a low-risk signal when we survey patients with NPCs. So this has been published. You can see that the red figures are the patient with cancer. The circles on the bottom are patients without cancer. So you can see there is a nice separation of the signals among NPCs and those patients without NPCs. So this is to highlight the publication of this technique using the Raman spectroscopy to use for surveillance of nasopharyngeal cancers. And this has been currently further in evaluation for clinical trials. Next, we want to talk about the clinical trials integrating immunotherapy for recurrent NPC. So this is one of the NCI meeting in Phoenix, USA in 2017. Where a group of surgeons, researchers, medical, as well as radiation oncologists came together to design trials evaluating the value of immunotherapy in the treatment landscape of nasopharyngeal cancers. So I was involved in the recurrent NPC group and co-lead with John Womberg from Toronto. And essentially, this is one of the designs that we discussed. And we said that perhaps this is a recurrent NPC treated with either surgery or re-irradiation, and patients will then be randomized to receive immunotherapy for 4 to 6 months versus observations. And we can stratify the group of patients based on the stage of the disease, the surgical margins, plasma DNA, and the time of relapse, and see whether there is a meaningful use of IO in the adjuvant phase. Sorry, pardon for this. This is not so clear, but this is just to highlight another trial that is already open, I believe, in Hong Kong, where they use a neoadjuvant immunotherapy with pembrolizumab, which is an anti-PD-1 antibody with chemotherapy. And this group of patients are deemed not good candidate for surgical salvage, but they will then receive neoadjuvant IO and chemotherapy to downsize the tumor before surgery. This is still, I believe, in the infancy, but I have the privilege of following up with one Singaporean patient who was on this study, and therefore it led me to understand more about the trial design. So the patient was seen here with recurrent NPC. As you can see, it's a submucosal bulge after treating with NPC, I think about 5-6 years ago. So this was biopsy proven to be nasopharynx cancer. And you can see on the PET imaging, there was deeper extension involving the clival bone to of sufficient depth that we think that this is not an ideal candidate for surgical salvage for this group of patients. So unfortunately, he did not want to consider RT because of the potential toxicities. So because he is based to work in Hong Kong, he got connected to the group at Queen Mary, and they offered him that trial I was explaining to you earlier. He was given 6 cycles of pembrolizumab with gemcitabine and cisplatin. And after finishing the 6 cycles of treatment, he had surgery in Hong Kong, and he came back for follow-up, and this was the endoscopic view of his nasopharynx. And currently, he is disease-free. And what I understand from the pathology report, after 6 cycles, the cancer essentially shrunk to about 2 to 3 millimeters. So this is still anecdotal, but certainly you need the trial to see whether this strategy can be effective in equipping surgeons to better treat our patients with salvage nasopharyngectomy. Well, this is another candidate who I believe is a potential candidate for the trial. So this patient had a nasopharyngectomy at another center about 5 years ago, and currently disease-free under follow-up with me. Unfortunately, he presents with a bulge here. You can see this crust is about a week after the biopsy. So this is basically already, this entire space is a sphenoid cavity, the sphenoid sinus. This is the remaining part of the clival and the roof of the nasopharynx. So this was the nodule that was biopsy, and now there is a little crust over the area. But if you examine the nasopharynx more carefully, you can see on the sphenoid sinus, there is this irregular mucosa that's tracking under the surface of the mucosa, closing to the lateral wall of the sphenoid sinus. And because of this imaging finding, plus the fact that on the MRI, that also shows a more infiltrated pattern involving the pterygoid plates and the pterygoid muscles. So he was not deemed suitable for salvage surgery. So currently, we are still exploring the options of re-radiation or putting him on the study mentioned earlier with IO and chemotherapy, and then evaluating the treatment response to see whether he can be a candidate for salvage surgery after that. In the remaining 10-15 minutes, I just want to highlight the role of immunotherapy, partly because of my interest in cancer immunology, as mentioned by Chwee earlier. So we look at one of the options of cell-based therapy by extracting the TILs, which is a tumor-infiltrating lymphocytes for nasopharyngeal cancers. So we found that we were able to extract nice numbers of TILs coming from treatment-naive NPCs. And when we compared the TILs in killing NPC cells with T cells isolated from the blood, we found that the TILs were better in killing NPC cells compared to the T cells harvested from the blood from the same patient, as illustrated here on the graph. And next, because we know NPC is EBV driven, so we then prime the T cells using peptides of EBV. And then when we test the killing of the NPC using whether it is EBV prime TILs or unprimed TILs, we found there were no significant differences among the T cells that were primed with EBV or unprimed. So demonstrating that EBV priming may not necessarily be superior in using these TILs for cancer treatment. I'd like to show figure 4, essentially is a spheroid model. This video shows untreated spheroids of NPCs. And you can see that the cancer is surviving well over the 48 hours where this is a live imaging videos. And when we treated the spheroids with the tails of a HLA matched donor, you can see after the tails is being given, the spheroids will be destroyed. So this is at least on the in vitro that the tails are highly effective to kill NPC cells. This is just a consolidated figure just to show that this purple line is NPC cells without treatment, and the other three lines will represent TILs killing the NPC cells, whether with EBV prime or without EBV prime, demonstrating significant anti-NPC effects in killing the NPC in vitro. So besides TIL treatment, there are also vaccines used in NPC. This is a collaboration with one of the scientists at NUS, Herbert Schwartz, who had this dendritic cell vaccine loaded with a CD137 ligand and against EBV. And it shows that in this study, they were able to show that when you add this vaccine, either in a very small, modest number of 12 patients, they were able to see a anti-NPC effects among this group of patients. Similarly, for my group, in collaboration with Dario Campana as well as Prof. Goh Boon-Che, we showed that using expanded natural killer cells in combination with cetuximab, anti-EGFR antibody, we're able to treat this in a small cohort in a phase 1 design. About 11 patients were accrued for these studies, and we're able to show that the objective response in this heavily treated recurrent NPC or metastatic NPC patients were able to demonstrate modest treatment effect, about 15% of prolonging the disease-specific survival in this group of patients. So to summarize, recurrent NPC certainly occurs about 10-15% of previously treated NPC. Surgeons required because surgical salvage is warranted whenever it's feasible, because that certainly is more superior than re-irradiation. And endoscopic or robotic-assisted approaches are feasible, but in very selected cases. Early diagnosis of recurrent NPC is key to improving the outcome of this group of patients. There are emerging newer surveillance tools that can be integrated into the practice in development, both in liquid biopsies and in optical imaging. And certainly clinical trials are required to test the feasibility of adding either chemotherapy or immunotherapy in the surgical salvage treatment of NPC, either in a neoadjuvant setting or the adjuvant setting. So I believe there will be new information coming along the trials, and we look forward to the time. Right, just want to thank again Peter and the committee for the invitation to join in this nice symposium webinar. And this are my email, and happy to email me if you have further questions on the talk. Finally, end off with the thank you, Peter and his family for their hospitality whenever we are in Hong Kong, not Hong Kong, Taipei. And certainly this is just the recent catch up in Montreal after a 3-year period after COVID in last year's North America Head and Neck meeting. Thank you so much again for this wonderful webinar. Happy to take questions from now.
Thank you, Dr. Ling, for this very comprehensive lecture about the recurrent NPC treatment, and a very inspiring NPC diagnostic tools and further treatment options for the patients. Now we open to the floor to is there any questions about today's topic?
Well, I guess there is no questions, but undoubted, this is most wonderful lecture I have ever heard about NPC, and I have to honestly, I have to congratulate Professor Lin Ming to give this talk, and also to to thank you for the past cooperation with you and me, and also with in working together in Asia. I have to say that I was the GMAS lecturer in 2014. My topic is actually about recurrent NPC, but you mentioned about Professor William Wei, and he was the GMAS lecturer back to 1993, and his topic is salvage surgery for recurrent NPC. And I have his first slides in my pocket for more than 10 years. And after his talk in 1993, 11 months later in 2014, I will be able to, actually 20 years later, I will be I'm honored to give a lecture. However, my topic on NPC and my topic will be from molecular the management of recurrent NPC from molecular diagnosis to salvage surgery. And now today is 2024, and we are lucky to listen to your talk, Ming. You extend the territory of how we manage the NPC, not only for molecular diagnosis, but you also extend, the field to incorporate with the recent advance in not only in technology, in molecular diagnosis, and in Raman spectroscopy, and also importantly with the current cutting edge, immunotherapy. And I believe that will be the new direction, the real new direction for to help us to treat this disease. NPC is a disease of Asia. NPC is not only, people in Asia are particularly susceptible to NPC, and so living in Asia, working in Asia, we have the challenges and also have the opportunities to treat our patient with NPC, and this is the disease of Asia, not only a disease of Chinese. And so I guess I would, you keep on your work, and certainly I would announce you to be, the next GMAS lectures from Asia. I hope in about 10 years, because William Wei was in 1993, and I was in 2014, and so perhaps in another 5 or 6 years, and you could be the GMAS lectures. And again, thank you for supporting me. Thank you for supporting the my retirement webinar, and I'm very honored to be your friend, and thank you, of course, for all the treat, and your friendship. Whenever we met in meetings, we'll spend at least some time together and have a drink or have a dinner together. So honor to, and there's a lot of comments from the floor. So there is one from Marinda, and so her question is: after nasopharyngeectomy or modified radical neck dissection, do you still to give another chemotherapy?
Yeah. Thanks so much, Melinda, for the question. So for positive margins in after salvage nasopharyngectomy, or for after a neck dissection for a neck nodal disease with extensive extranodal extension, so these are two key poor prognostic markers after surgery. So generally, we would consider giving re-RT adjuvant in an adjuvant setting for this group of patients. I would typically discuss this in a multidisciplinary tumor board with our medical as well as radiation oncologists, and they do consider that in these two particular settings. The role of adding chemotherapy with re-RT is controversial. Depending on which studies, some have shown a modest effect of adding chemotherapy in the adjuvant setting, unlike the squamous cell cancer, where if you have positive margins and or extranodal extension, chemo-RT as an adjuvant post-op setting is quite standard. By NPC, I think this information is still not too mature, but certainly I would consider discussing that with our medical oncologists in this setting. Previously, when I was a resident for very gross extranodal extension for neck dissection, as you remember, Chris, who everybody is familiar, he collaborated with a radiation oncologist, put brachy rods. So after a neck dissection with gross ECS, he will then put the brachy rods and then put in a PEG flap. And then the patients would then go for brachytherapy. But I've not seen that for a long period now. I'm not sure whether in other parts of the world and centers, do they still do that? Brachy, so they deliver very high concentration of the radiation in a strategic area. But I've not seen that since. But certainly RT in this setting is possible for those patients with gross extracapsular spread diseases. Yeah.
Actually, we don't like brachytherapy mainly because you know, you can really calculate the dose distribution, and so if you can calculate the dose distribution, then you would have a very high rate of complications, and we don't really love complications, especially after neck dissection, the carotid artery exposed. Even you rub up with a PEG flap, and you enter the brachytherapy, you know, and so anyway, I think brachytherapy is a choice, but I guess in Taiwan, rarely used now. Yeah.
Yeah. Same in Singapore. I have not seen it for a long time. Yeah.
Yeah. Is there any more questions? If there isn't, then thank you, Chwee, and certainly I'd love to catch up with you in some other meetings. And thank you so much for supporting me and supporting us. And now I have to announce for the April meeting. In April, we are going to have 6, retirement virtual webinar. And the topic will cover the robotic surgery and the reconstruction, and also, thyroid cancer, central compartment neck dissection. And also, we invite our friends, Namaya Thapa from Naples, and she is going to talk about ENT services. And then also a speaker from Poland, Dr. Łukasz Goludzinski, and he is talking about the basic research and the translational research as well. And then the Professor, our friend, Professor Alfredo Pontejos. Yeah, and so thank you for your participation, and look forward to meeting you again online, in next week. So thank you, Chwee, again, and thank you for all your participation, and have a good day. Thank you. Bye-bye.
Bye-bye. Thanks so much, Peter.
Thank you. Bye.
And the team. Thank you. Bye-bye. Nice to see you, Parable.
Thanks. Good to see you, Shwee. Great talk.
Yeah.
Thanks, Peter.
Thank you. Yeah.
Yeah, Petrobras.
Bye.
Yep. Yeah.